everybody, welcome to the T3 Fit Scoliosis podcast. On today's episode, I am just going to start out by saying I am super excited about this. We are having Dr. Lonner on the show. He deals with tethering. He is an orthopedic for scoliosis. I'm going to say again, I'm super excited. He's here today to talk to us about the procedure, when it started, how he got into it, and just a bunch of questions that we're going to roll out. So I'm just going to give him the floor and say, Dr. Lonner, welcome to the show.
Teresa, thank you for having me, and it's a pleasure to be here with you and your audience today. I look forward to getting into our conversation about vertebral body tethering.
Absolutely. So I'm going to start out with the first question is, can you explain to us what tethering is?
Sure. Well, tethering is also known as vertebral body tethering, or VBT, and also another name is ASC, Anterior Scoliosis Correction. But basically what it is, it's a way that through surgery that we can correct scoliosis, but without fusing the spine, because the standard operation has been and still really is throughout the world and in the United States has been spinal fusion, where we basically place screws and two solid metal rods along the spine and basically correct the curve, but also stabilize and fix the spine in that position. So it's kind of like a biological welding of the spine together, and we form a solid column of bone, and that's the fusion process. So this is something very new and exciting, and has been revolutionary, and I would say, in my practice and for my patients. And this is my 26th year in practice, so to have such a wonderful procedure, and in our hands it's been quite successful for the vast majority of our patients, is to do this procedure where we correct the curve without fusing the spine. And we do that by going through the side through very small incisions, using a scope and a camera, so we can keep the incisions very small, but we still have good visualization. And we place screws across the vertebra, which are the building blocks of the spine. And then we attach those screws with a flexible cord. That's the tether. And then we tension it so that we get correction of the curve. And for patients who are growing, which is really where this is standardly indicated, although we have patients that are more on the skeletally mature side who don't have growth or have very little growth, and that's more controversial if you wanted to discuss that. But the tether basically allows us to correct the curve partially at the time of surgery. And then with growth, the curve corrects further. And so the patient straightens out over time. And so we have to be careful to time when we place the cord. If the curve is very small and the child has a lot of growth left, they may overcorrect and start to go in the opposite direction. And if they did that, we'd have to remove the cord, or at least remove parts of the cord or cut the cord. And then if they have a bigger curve and not a lot of growth, they may not correct adequately. So it's finding the right time to intervene, to do surgery, and also operating on curves that are flexible enough in order for us to get a satisfactory correction.
So when you talk about it being a small curve, what number are you talking about in terms of
So we generally operate on curves that are more than 40 degrees. So anything below that is probably too small. We have other options of, for a 35 or 40 degree curve, I could do another procedure where we go from the back and we can kind of place an internal brace, which is the step before surgery for patients who are growing, is to brace those patients. And sometimes they don't have a good result with bracing, and their curves get worse or progress. And then we can offer them an internal brace, a device called ApiFix. It's a different procedure.
And when you talk about the controversy of tethering, you were talking about that based on the age groups. Is that correct?
Right. That's right. So in my practice, I have some older patients and patients who are no longer growing. And, the concern about that is that the cord is not likely to last forever. It's probably going to give way, and it does give way in some of our patients. We might imagine that would happen in all patients, that eventually the cord will not stand up. But when we see those cords break, the tether break, it usually will break in one or two locations. Sometimes it breaks in multiple locations, but for the most part, the curves have been holding their correction largely, even in our more mature patients. So, but the controversy is that when the cord breaks, the curve's going to come right back to where it was. But so far, we're seeing really good outcomes. And in an adult patient who has a lumbar curve, so a curve in the non-ribbed lower portion of the back where most of our flexibility and function is, the only alternative is to fuse that area, and that really stiffens the spine. And if often the fusion has to be done to the very bottom of the spine, especially in patients with a lot of arthritis and degenerative discs, wear and tear of the discs. So you end up fusing the whole spine. Or if you fuse into the middle of the lumbar spine, or toward the end of it, the lower discs, the remaining discs, have a lot more stress and load on them. So they break down, and then the patients develop more back pain and sciatica, leg pain, numbness, tingling, weakness, and then they need fusion extended down. So the tether, even in our adult patients that we've applied this in, and we're going to write up our results eventually once we have long enough follow-up. But so far, those patients have done very well. They get to maintain their flexibility. They pursue their activities, and they understand that the cord may break and the curve could come back at least partially. If it doesn't get severe, then there's nothing to do. But eventually, we're going to have cords that are a tether that's going to be stronger, that will last longer. And a super duper tether that will last forever. And that's our hope. And I believe we'll be able to do that, my colleagues and I and engineers, as we develop with the company
and
the new systems.
What's the, I'm going to use this word intentionally, what's the most mature age group that you have had surgery, that you have performed surgery on?
I'm almost afraid to admit it here. In public forum, but I would say middle age. Let's put it that way. And I have to say those patients are very happy.
That's great.
It's not a huge number of patients because we're very, very careful about being selective and really, the patients and families understand that we're kind of forging the way together. But I have to say it's been quite impressive what we're able to do for some of these patients.
Yeah, I've met some of the people that you've performed this with and will be performing this with along the way, and the outcome has been really, I love seeing it because it's so different than my story, and the people that are coming to you in the future are just super excited and really looking forward to being pain-free. So would you share a little bit about what it's like if somebody comes to you and says, I have scoliosis, and how would you advise me? What's the process?
Sure. The vast majority of patients, when they come to you, they don't have severe curves. They have some scoliosis, and they just want to understand what is the natural history. What will happen to my back? What will the curve do? Will it get worse? If they're a growing child, which many of my patients are, we'll follow them over during their growth years and make sure that the curve doesn't get worse. And on the other hand, if they have a curvature that's, let's say, between 20 and 40 degrees and they're growing, then we'll recommend a brace. And they wear the brace, and we'll follow them closely till they reach the end of growth. We call that skeletal maturity. And then other patients come in with more severe curves, and our recommendation, and sometimes they're children who don't really have, their adolescent girls mostly, but some boys as well. They don't have a lot of pain in a lot of cases. Sometimes they have, but often they have very little pain. But we do know that if their curve is large enough, it's going to continue to progress even after growth has stopped in their adult years. And then they develop back pain and sciatica and problems later. So that's why we sometimes operate on, otherwise asymptomatic young people, because of what will happen over time. And so we then recommend surgery, and we provide all the options to the families. And I spend a lot of time not just talking to the parents, but to the the girl or boy who's going to be faced with this, because it's their body and, their fears
Yeah.
and their goals and aspirations are part of the discussion. So we talk about fusion, and that's always an option. We talk about tether, and we talk about this other device, the ApiFix device, where that's indicated. But I would say the majority of my patients nowadays have a tether procedure. I've really focused my practice in this area, so we do a lot of non-fusion corrections.
And you've been in this practice specifically with tethering for 26 years, is that correct?
No.
Okay.
So
Okay. Sorry.
tethering really, I've been practicing for 26 years, and I hope to have another 15 or so more to go, or who knows, maybe more if I'm lucky.
People need you.
As long as we're doing a good job for the patients and healthy. So the tether procedure really, as the first one done was about 10, 12 years ago, but the vast majority have been done in the last several years. And I've been doing this for 6 years now.
Okay.
And I have one of the largest experiences in the world at this point. We've done just under 400 cases, and we follow our patients very closely from all over the world. And sometimes you ask what the process is. A lot of times we'll follow from afar. So the patients will send their x-rays in, and we'll speak to them over the phone and check in with each other on Zoom calls and the like. So we stay connected.
Thank you, Zoom.
Yes, exactly.
Thank you, Zoom. Thank you, Zoom. And how long does a procedure take generally? I mean, I know it can vary depending, but is there a ballpark?
Yes. Some patients have a single curve, some have double curves. And so, if they have a single curve, that's going to takes less time. But our patients are in the operating room for quite a number of hours because we bring them into the room. The anesthesiologist puts in an IV, and our patients get an epidural so that after surgery, they're kept comfortable and they have control over a button that they press. So that takes some time. And then my team and I position our patient in the operating room on the table.
Okay.
And then we localize where we're going to make the incision, and then we prep and drape the patient, and then we start the surgery.
Okay.
And I work with a general surgeon on every single case. So we have 2 sets of hands in addition to our assistants in the room. And, then we do the operation, and then we take a final x-ray to make sure that everything is as we desire and as good a result as is humanly possible. And then the patient will wake up. So that's usually about 5 or 6 hours just for a single curve, and it's 2 or 3 hours more for a double curve.
Okay. And then once the patient has come out of surgery and they're in the recovery room, what's the procedure then to get them start to move and just to live life?
Right. So our patients are usually in the hospital for 3 or 4 days.
Okay.
Sometimes one day more than that, but generally 3 to 4 days. And then we tell them, no BLT, no bending, lifting, twisting for the first 6 weeks.
Okay.
But they're walking up and around, and they get out of bed the day after surgery with our physical therapy teams. And then they'll go home. And we hold to that no BLT for 6 weeks, but I encourage patients to get into the swimming pool at 3 weeks.
Okay.
And they can do kickboard, walking in the pool. It helps keep the core going, as you know better than anybody else. I like the swimming pool, and I like the kickboards. And so many of our patients are athletic and they get into the pool, but some don't like pools, so they don't do it. And then we get them to physical therapy at 6 weeks.
Okay.
And get them back to their activities. I've had some many high-level athletes over the years. One girl, for example, from Chile, from South America, she was a nationally ranked rhythmic gymnast.
Wow.
And she's amazing. She's a wonderful young lady. I was in touch with the family just recently, and she's almost 4 years post-operative now.
Okay.
But 3 months after her surgery, she competed and made the nationals. Was able to get into the nationals basically, based on her competition 3 months after surgery. So with a fusion, patients don't even start to get back to activities until at least 3 months. And we wouldn't permit rhythmic gymnastics or gymnastics and
Yeah.
certain dance. And often swimming is more difficult, especially if the fusion's taken down into the lumbar. So
Yeah.
we have a lot of high level swimmers, and they really get to their sport very nicely.
It's so amazing how it has changed over time because the Harrington rods are barely used now.
Right. The Harrington rod was a single rod with a hook that goes up and a hook that goes down. And yeah, that's what you had. Yeah, you had the hook up and hook down.
Yeah.
You seem too young for that.
I'm 51.
Yeah, that's,
I had the surgery in 82, 83.
okay. Yeah, so that's
So
about right. Yeah.
yeah.
And they were longer fusions then, right?
Yeah.
So
I have straight
now,
down.
now when we do a fusion, we tend to do much shorter. And
Mhm.
in my practice, I push the envelope of the non-fusion because I just think it's really great to offer it to the patients. And I think especially in the lumbar spine,
Mhm.
to try to preserve as much mobility and avoid the problems, I think it's good to not fuse.
It's so important because so many people that I've spoken to along the way, our bodies are taken from us in a way with scoliosis, and you are the example of not allowing that to happen, to say give the patient their choice.
Exactly. And it's interesting, Teresa, that you say that. It's I tell the families what we know, what we
Mhm.
don't know.
Yeah.
We don't have long-term follow-up, and time will tell, but we play out the scenario as they might occur. So if the cord breaks and the curve stays roughly where it is, that's great. And the patients don't need anything done. If the cord breaks, we see it on an x-ray.
Mhm.
Generally, they don't even experience symptoms. They don't even have pain. Um, if the curve comes back a little bit, probably don't need to do anything. If the curve came back fully, the patient has options. One is do nothing. Two is put in a new cord, and we're going to have those um, zooped up cords, special
Mhm.
cords, I think, in the
Right.
future. And they also always have the option for a spinal fusion. So they're given all that information, what we know, what we don't know, how the scenarios might play out, and then the families and the patient gets to choose. And sometimes mother or father or the family says to me, doctor, even if it doesn't work out in the future, or if my daughter needs something later in life, she'll be able to decide. But for now, I don't want her to have a fusion or him to have a fusion, because that's permanently altering their body. And I want her or him to have that option later in life to decide for themselves.
And
So it's an interesting
yeah, and
perspective.
you provide such a support for that. You don't say it's one way or the other.
No, it's not for me to do, because
Yeah.
we don't have long-term follow-up, and it isn't the standard operation. It's for me to provide as much information as I can, to be
Mhm.
a guide and counsel the families, and I'm very available to them. We often have multiple phone calls and conversations, nights and weekends as well. And we get through the process together, but I would say most of the families choose tether, um, for me, at least in my practice. And,
Okay.
some families will say, well, I saw this other doctor and he says I'm not a good candidate, or the curve is in the lumbar spine and that's dangerous, and to do a tether. And the answer is that's not true. It isn't dangerous. We've done so many cases, and the reason other doctors may not feel comfortable or feel that it's dangerous because they don't have the experience with these approaches. So 26 years ago, when I started practice, I started doing approaches through the side, and that was for fusion then.
Mhm.
But we did a lot of those approaches, which are the same identical approach as we do today.
Mhm.
Um, our incisions are even smaller now than they were, but
Right.
we were using a scope and camera back then. And so I have a lot of comfort. And, when we teach the young doctors that are passing through, or even senior doctors that come for training, there's that learning curve and they have to learn that. And so it takes time and education and training, but very few of the patients aren't candidates for tether in my
Okay.
practice.
Okay. And that leads me to the next question. So there are going to be people that are going to hear this and I hope that they jump on this because it's an opportunity that I feel like it's kind of in the space of also of Schroth. It's just now starting to evolve.
Yes.
So, and get thankfully popular because, like I said before, it's very different than my story. I have Harrington rods. But if people want to find you on social media, where is the best place that they can reach out to you and your team?
Probably they can call my assistant, Patricia.
Okay.
That's one way. And that's 212-241-8312. And then we have a website that's kind of a website that I've had for many years of my practice. I'm now at Mount Sinai Hospital, but my personal website is scoliosisassociates.com. So it's
Okay.
one word, Scoliosis Associates.
Okay.
And I think we have an Instagram, and it's a Scoliosis Fixer.
Correct.
Yes.
That's where I found you.
Yes, that's what it is. And the Scoliosis Fixer, we have some educational videos that are going to be coming out soon. We'll have some of those on Instagram and some on our Facebook. But, my goal is to really, with my website, for example, is to educate families, and we're going to be updating the website. But the Instagram is a lot of thumbs up. It's me with patients and them doing their activities and getting back to life. And I just feel like it illustrates for the families who are seeking information and kind of allays some of their fears. You can see patients getting back, young ladies and young men getting back to their lives and doing so well. So that's kind of what we do with our Instagram.
Okay. I wish Instagram was around when I had my surgery, when I was diagnosed. I wish you were around when I was diagnosed. Life would be very different. But I want to personally thank you for just coming and giving me some of your time to be a guest on the show, because it's, like I said before, there are people that that you have done surgery on and that you will be doing surgery on. And the connection that you have with those patients, I've never heard anything like it before.
Thank you so much. I really feel, we say doctors have privileges at such and such a hospital. Well, I feel privileged to be able to take care of patients and, to pursue what I love to do, and that is to take care of patients and help restore their function for those who have pain and problems, and also restore their body shape. And it's really rewarding for me. And so I know there's a lot of fear for the families. And so I try to make myself available. And, after surgery, the patients and the families have my phone number, personal phone number.
Yeah.
So I do my best. And I really appreciate that we have such wonderful patients from around the world. And I think you're doing terrific work and service through your, you're taking care of individuals and keeping them fit, but also through your podcast. I think it's a great service.
Thank you. Well, I can't thank you enough.
Thank you so much, Teresa.
I thank you for being a guest on the T3 Fit Scoliosis podcast. If anybody has any questions, please feel free to reach out to Dr. Lonner. I know him through Instagram. His team will get in touch with you. He has also given the phone number. Dr. Lonner, thank you.
Thank you. Be well. Take care.